watch her when she walks around. Like her heels are not touching the ground when she walks. Like she's going to get a raging Achilles tendinopathy if she continues to do that, because it's like someone who has limited knee extension after an ACL, they walk around in a bent knee and get a really bad quad tendinopathy because it's just, there's no break.
Every day, you essentially pay your dues by doing the harder thing when it's the right thing to do.
All right, so we'll get started here and then more people will join as we do it. First of all, thank you guys for joining us and gals for joining us. So I'm happy to have everyone here. And I just want to run through a couple things real quick. So one is welcome to what we're working on here today. I do want to give a small little intro. You guys won't see our whole team. I'm flattered that Shift has a team now, which essentially just grew because I couldn't do it all myself and I was drowning in work. But for those that are not familiar with me, my name's Dave. So I'm a physical therapist, board certified in sports. I'm a strength coach. And then I run this beast, whatever we're calling this now these days, called Shift, which is a company for education and consulting. And then I still coach gymnastics on the side as well. So unfortunately, you will not get to meet the whole team tonight because they are out and about. Becky lives in Australia, so she has her own stuff she's doing in the morning. But Sarah is here, the wonderful Sarah, who she is a digital media employee of Shift. And she also is my left hand for helping me collect my life together. She was a gymnast. And if anyone has seen the short films that have gone viral on YouTube, they are 100% Sarah, not me, including the one that special shout out has 40K views right now. So Sarah does all of the handiwork behind the scenes for all of our short film stuff. And she also helps me kind of run these Q&As. She's becoming an assistant. She's pretty much doing everything. And I'm learning that I can't without her. So two people you won't meet tonight, unfortunately, but Taylor is our analytics and support staff. So she also is a coach. She likes all the numbers that we don't like to deal with. And then Becky, if you've ever seen anything from the podcast, she does it all. She really, I literally just film it and make an intro and offer some thoughts on captions and ideas, but she really does all the quotes, all the editing, all the YouTube stuff. So it looks like I'm doing a lot more than I am. A lot of people, especially in this group of medical providers, ask how I can manage my time and how I do stuff. I have the first 5 years I did do it myself, but it wasn't that great. And now that I have a team, that's the real reason why I'm able to do more work. So just a short background on that. And then we do want to say quickly, because this is the crowd who is probably interested in this, that we have launched something very exciting for gymnastics medical providers this week. So anybody who's familiar with Shift, we have 3 full courses that are 10 hours. You get to hear me talk way too much about stuff that I get excited about. I talk too fast. I've heard that comment a lot because I'm a massive nerd and I get excited when I talk about it. You will notice a special star of all these courses, Jan, who is in here right now. So she has done all of the filming for all of these things. She's a rock star. But we heard from a lot of the people that the information was amazing and they want to go through it, but it's like getting water from a firing hose when you're trying to take a drink, right? So we summarize these courses into 25-page handbooks that an amazing student who took the course started the project. And then myself and Jan and Jen and Keisha and a bunch of other people went through and kind of edited it and added our thoughts. And so it's pretty much got everything from the 30 hours of the courses in a quick little PDF cheat sheet that you can have on your desktop at the clinic. That's exactly why I needed it, because I valued it because I could quickly look up some tests or I could quickly look up something that maybe I forgot. So if you guys are interested in that, those are getting released this week and there's a link below, but Sarah will also drop it in the chat. So any questions you have, feel free to reach out to us. But wanted to just mention that because I know a lot of people might be interested in that and kind of looking for something to help them in the clinic. It also may summarize a lot of the stuff that we talk about here tonight. So on to the good stuff. The way we're going to run this tonight is it started because a lot of people, I get a lot of DMs and emails and I'm happy to help people. Like I'm never not wanting to help people, but there's just a bandwidth on my time and how much I can really put into long DMs. And it's also, I hate answering emails about medical questions, not because I don't want to do it, but because you can't have a fluid discussion about the nuances and the complexities of rehab. And it's not all black and white like people want it to make it to be sometimes. So I like these kind of interactions on like the podcast or when I talk with people and mentor them, because we can actually go back and forth and clarify and make sure somebody really gets their question answered. It's not like there's nothing I hate more than when I really have a question for someone and they really give me like a quick little answer and then like, all right, good luck. It's like, okay, well, I have a couple more follow-up questions than that. And it's not as easy as that. So I want to start these as a regular thing. We've done one for coaches that was really popular. And I think we're going to try to just do one a month or one every other month for like coaches and medical providers. And then also, if we get more people in the mix, that'd be fun. But the reason is because like it's confusing and it's challenging in rehab. And I still have questions. I ask Mike and Lenny, if you guys aren't familiar, Mike Ronald, Lenny Macrina, I ask them questions all the time, and I still need help, and I'm still asking things. I'm still reading. I'm constantly trying to evolve my thought process. And for everybody that's out there in the gymnastics world, like the sport of gymnastics itself is changing very, very quickly, but the medical care is changing at a blistering rate as well. Like 10 years ago, when I was just starting out in grad school, it was a very simplistic approach to how I thought medical care was done in gymnastics. And now that I'm 10 years past that, it's like, a lot of strength conditioning is changing. A lot of new things like BFR and different modalities are coming out. And so I think that has yet to make its way into the medical research for gymnastics, which means that we're really only seeing epidemiology. We're only seeing diagnostic factors. We're only seeing very basic things about how to treat somebody. And anybody here as a clinician knows that the research is about 2 or 3 years behind what we're actually doing in the clinic. So I wanted to provide an opportunity to have some discussions about that. So let me just chat about this first, because this is on my mind right now. I'm treating a gymnast, a very high level gymnast with a PAO. I'm not sure if anybody's heard about this, but a periacetabular osteotomy. So this is a doozy, right? And I am deep in the world of hip dysplasia right now and hip micro instability, just because of the cases that I'm seeing, but also because of the people that I've been lucky to interact with. Mike Ryman is a perfect example. He's someone who like put a large course out on this. And it's really like an unknown beast of like how to treat these athletes. And so having treated a lot of gymnasts for hip pain, I just want to share some of like the kind of clinical ideas that I've been working with really successfully. And then I think is helping this gymnast right now. She is 3 months out, but I started treating her around the 6-week mark because she went somewhere else. But on the diagnostic side, I just took Mike's course and I was reading about this. And there's a couple really important radiographic findings that I think people should be asking their surgeons about and should be thinking about either pre-op or not op. But one being something called a lateral setter edge angle. So the angle of the middle of the femur up and how far it goes out to the lateral wall of the acetabulum is a measure of overcoverage of the hip. And 5 years ago, I didn't know that existed. I had no idea what that meant. And I didn't really know how they measured acetabular overcoverage really specifically on radiographs. And the people who have under 30 are kind of considered dysplastic on micro, instability imaging, that kind of stuff. So someone who is under 30 is considered at a shallow angle. And this athlete who I was treating before she went to surgery, hers was 8. So she had 8 degrees of a ton of that angle, which meant she was severely dysplastic. And she actually didn't have a labral tear, but she was having like significant micro instability. And she was having a lot of hip pain, a lot of lateral issues, a lot of anterior issues. So that was like a really important thing for me to find, because they correct that under surgery when they actually do the replacement. So I'll talk about the surgery in a second. But the second thing they measure sometimes is a tonus angle. So they measure from the top of the actual femoral head to the same thing, the outer edge of the acetabulum. So I think that is going to be something that's really important to think about too, because that's going to measure, again, the distance this way, right between the angle versus this is my terrible stick figure help, but the lateral center edge angle is this way, sideways, right? And they also do an anterior center edge angle as well. So from the side of the person looking forward at the acetabular overcoverage. And there's a lot more to it you can measure, but those 3 things are very, very important to talk with surgeons about or ask people about, or even if they're coming for you for non-operative rehab, they just have like a labral issue, hip flexor strains. You want to know if that person is micro unstable from a dysplastic point of view. And dysplasia is a X-ray radiology diagnostic. It's not a clinical diagnostic. So Mike was talking to me a lot about those 3 measurements and why they're so important, because if somebody comes in with a really low center edge angle and they come in with a really low tonus angle and they have a high Beighton scale, that person is really riding on static stability, pretty hard. They have a lack of static stability, so they're riding on dynamic stability pretty hard. So I thought that was very useful to talk to the surgeon and talk about that. But a couple of like things I really learned from reading, I don't have the textbook in front of me, but Shane No has a really great textbook on hips that he edited with Dr. Kelly, who's the girl who did one of the surgeries for the girls that I'm treating. And a couple things to think about is the psoas tendon is an anterior stabilizer to the femoral head. So it's a big reason why people have a lot of problems after surgery or even before surgery with like aggressive stretching and stuff like that. I did not know that when I was a younger clinician, that the psoas tendon itself actually is a dynamic stabilizer against femoral head motion forward. So that's important to think about. Another thing that I learned from the surgeon is that the rectus femoris has a capsular attachment. So it dives actually into the hip and attaches to the actual anterior capsule. So you think about what happens a lot in like aggressive stretching, switch leaps, stuff like that, jumps and leaps. I think a lot of people have very quick diagnosis of like hip flexor strains, or they have adductor strains, when in reality, I think the psoas tendon I think the rectus femoris tendon that directly attached to some of these deeper structures are really, the issue. They're really hanging on for dear life. And so on the non-operative side, it's important to realize how loose somebody is and why we need to correct their stretching or really be careful about what they're doing from a strength conditioning point of view if they're having hip pain, because it might be literally pulling on some of their deeper static stabilizers like the iliofemoral ligament and the labral tissue. Again, just something I never thought about when I was a younger clinician. And if someone does have a surgery, they oftentimes will move those things around, or they will have to, pull those things down to get at the deeper hip capsule. And so you're going to have someone who's really, really sensitive in the front of their hip joint, but they hold off on a lot of restrictions and precautions because of that. And I think sometimes people don't really understand the anatomy really in depth there. So a lot of times when they do either like a femoral osteochondroplasty or some sort of labral repair, they have to put a portal between the iliofemoral ligament bands. And that is, very indicative of where someone is sore sometimes. So just keep in mind those things, because I never understood any of this when I was younger. I did not get any training specifically on hips, but the idea about the dynamic stabilizers of the hip flexor and the quad, right, of the tendon, rectus femoris tendon, the fact they go through the hip capsule to do some of the work and they literally pierce around the ligaments. And then also it comes down to when they're out of the surgical side of things and they're coming back, I think a lot of times people are understandably nervous for hip flexion, right? Because they're worried about maybe impinging some of that soft tissue or kind of having some issues come up along the osteochondral side where they worked on. But it's really wild to me how more irritable people tend to be with extension movements, right? So they limit extension for 6 weeks. And then I think sometimes people go a little bit too aggressive on like Thomas test type stretching or just trying to get hip extension back. And it really irritates a lot of the deeper structures. So I've made mistakes of pushing people a little bit too far, either non-operatively when I thought they were okay with extension, or post-operatively when they had some issues like that. And I've learned the hard way that you really do have to respect going slow that way. So yeah, just a really interesting case for anybody that's not familiar. A PAO, or a periacetabular osteotomy, is when they actually, I can't believe the surgery is a thing, but they essentially just break the entire hemipelvis. They carve through all the parts of the pubis and the rami, and they just like shift it to make it more over coverage. So they anteriorly shift it and they rotate it. So it's like, okay, now you have more of a over coverage, which is wild to me. It's just so bizarre. The surgery was 7 hours for this girl. And ironically, this is not funny, but it's funny. The surgeon is a patient of ours at the clinic because his hips hurt when he stands for surgeries for a long time. So he has labral issues in his hips because he stands so long for surgeries. And one of my coworkers treats him. But yeah, it's wild. So you're seeing a lot more. I think PAOs are a really aggressive end stage treatment for someone who's had a long history. This girl's a level 10, did elite for a while, has a scholarship next year. And it's kind of like, all right, we got to get this thing fixed so we can go on to college. Most of the times they're doing more like, labral repairs and some, osseous changes or some capsule reductions because they're so unstable. But yeah, I just think that as I'm working through the process now, I've treated people previously who had similar types of surgeries but this is the biggest one I've ever treated. It was quite aggressive. So I'm just learning a lot, and I wanted to hopefully share some of that stuff with you. Not that I think people are going to be treating PAOs, but some of those concepts around the radiographic findings, the deeper layers of the hip, the structures of the hip, the dynamic stabilizers of the hip. I think those are very, very important for rehab, being able to train those at a high level. And I think sometimes I missed that completely when I was a younger clinician. So yeah, just want to start with that because it's literally fresh on my mind right now. But yeah, does anyone have anything they want to talk about? Anybody have any questions? I could literally just ramble on about some of this geeky stuff, but I'm happy to do this.
I just have one gymnast in particular. I do privates with her several days a week, and every time she has trouble with tumbling because her feet just turn in. So every time she tumbles, she complains about her ankles.
Yeah.
And I'm a PTA, but it's frustrating because then parents come to me and they're like, "Oh, can we do this? Can we do this?" I'm like, "I can't diagnose. You're gonna have to take her in somewhere."
Yeah,
but is there
fix her now, please? Fix her now.
Yeah. Is there anything I could do like at the gym?
Yeah.
Exercise wise?
Absolutely. Yeah. I think, does she have any symptoms or no?
She just complains specifically when she tumbles that her ankles hurt, and she lands wrong quite often, and her ankles will kind of roll sometimes.
Yeah. So lateral ankle pain or like bottom of her foot pain?
She complains of lateral ankle pain. Her foot sinks in that way.
Yep.
Medially. But she complains of the pain on the outside.
Got it. Okay. Yeah. So usually what I kind of find is a case here is when they're overpronating so much, just to frame the context, is that they're impinging the lateral talus on the malleoli, right? So they're getting so much pronation that they're everting and they're getting a lot of pain there. And it kind of compresses some of the capsular tissue and some of the other like bony structures. Yeah, so this is definitely, I mean, anybody in here can probably talk about 5 stories of treating people with like really, rotated in ankles or plantar collapsed feet and arches. So yeah, I think the number one thing I always am trying to figure out in my head, and this is kind of general advice for any eval that I've talked to some of the students about, is like I'm always trying to think about what are the issues at the ankle I need to screen, and then what are the issues not at the ankle that could be contributing that I need to screen. So we'll start kind of locally and work our way up. So yeah, number one thing is always like half kneeling dorsiflexion tests. So to see if they have, a lot of kids will cheat those dorsiflexion tests really, really well. So you'll do like a 5-inch ankle screen and you say like, all right, need a wall. And it's like, they flatten their foot out, they rotate their toe out, and they also kind of like lift their heel slightly. And it looks like they can get dorsiflexion when they go towards like their first column or their big toe, right? It's not so much accurate. And I think that shows up sometimes in their tumbling and their running. So you have to be very specific when you screen them about like, I want you to put your knee towards your pinky toe. You're not allowed to flatten your arch. And I'll sometimes put my fingers underneath their inside of their foot to make them not squish my fingers, or just a piece of cardboard or something to do that. And then you have to keep your heel down, and I literally hold their heel down. So number one is oftentimes when people get really true, accurate assessments of dorsiflexion, they're extremely limited because they're used to kind of rolling in. So I would screen that first. I would go for like a true half kneeling dorsiflexion test. Go knee towards pinky, keep your heel down, and don't let them tibially rotate at all. The other way to kind of measure that is a single leg step down. I think I'm learning this more, but half kneeling dorsiflexion tests are very good at like horizontal force displacement, so they can push like straight over their toe. But a lot of these athletes have problems with vertical displacement. And so it's different when the entire kinetic chain is stacked on top of their body and what their foot does versus when they're against the wall doing a dorsiflexion test. So I will screen both, right? I'll screen the loaded range of motion, but I do want to see what happens when they're vertically displaced. So I'll have them do a single leg step down off a high box and give them a dowel to hold and just see what happens with their foot. And I'll actually measure that as well. So I've been doing that more and more as a helpful way to kind of mimic like jumping and landing patterns. Cause I've had some athletes that whether it's a strength or a mobility issue, like look okay on the screening on the half kneeling test, but then they completely fall apart when they do a step down test. So that would be the first place to start with, is just screener, right? And see, do you have the motion? And then see, if you have the motion, if you don't have the motion, why don't you have the motion? So you ask them like, hey, do you feel it in the front of your ankle? Do you feel like it's a block there? Do you feel like a stretch in the back of your soleus or your Achilles? Do you have any other pain or symptoms like that? And then you kind of go down the rabbit hole that way of like, okay, if it's a joint issue, you might not be able to diagnose that, but like, what are some strategies that we can use from a joint mobilization point of view? A lot of gymnasts have chronic plantar flexion, so they really lose posterior capsule mobility to get their TC joint to glide backwards. So they lose dorsiflexion partially because of that. Some athletes have gnarly cartilage issues in the front of their ankle because they've been whacking their talar domes for so long. So sometimes it's more of a static thing you can't change, and you might need an x-ray to rule out, like, if you have a pretty big, bump across your talar dome, it doesn't matter how much mobilizations you do, you're not going to get any dorsiflexion. So that's probably an elimination diagnosis. And then if they feel like back of the ankle stretching or calf stretching, you would do some soleus work, foam rolling, eccentrics to the calf with a bent leg, seated calf raises with a nice 3-second lower deficit are really good for mobility. I like those a lot. And I also try to look at great toe extension also when they're doing some of that stuff. So getting 60 degrees of great toe extension, because these pronation issues sometimes show up when they run as well. And you obviously don't need toe extension when you land, but you sprint for floor and vault. Some kids really have a lot of foot pain because they're running, they have no toe extension, and they just like pronate over that way. So check ankle mobility, see if it's a joint or a soft tissue, check big toe extension. If they're completely clear on all of those tests, they have no mobility restrictions, which is hard to come by, but if they're younger, sometimes that happens. It's really more of a strength and then above the road issue. So you can do local strength. I think any single leg work is probably going to be the best there. So I really like single leg offset RDLs. So just single leg on the opposite hand, drop down, because this is a tangent, but there's kind of like 3 things for an RDL I'm doing on a single leg. One is like a straight up balance and control of the foot and the hip, which is the offset. So it's in the opposite hand of their foot. There's a kickstand RDL, which is more to like you put your toe down in the back just to get heavier loading. So balance is not really the main factor. And then there's a true single leg RDL. So you have 2 weights in your hands and you're doing an RDL, which is probably more on the strength balance kind of hybrid. So for her case, where she's trying to get foot control or foot strength to kind of raise her arches up, I would probably have her do an offset one-handed single leg RDL and just try to work on pulling that foot up and kind of holding a nice shelf in her toe that way. So there are strength work you can do, like single leg calf work seated and standing also works that really, really well. Like just walking kind of on the high toe with a dumbbell in your hand or doing eccentric slow lowers can build up the arch. So I enjoy those a lot. If you really have someone who the strength is not coming along, they have a really overpronated foot and it's not a mobility issue, the X braces are really great too. I'm not sure if you've heard of those, but my buddy Josh Eldridge made those. They're essentially like slip-on braces that help mimic the arch. And I like them because they force your intrinsic foot muscles to work really hard. They're not just a brace that does all the work for you. So people's feet are really, really sore when they do those. So that's at the ankle. And then, up the road, obviously looking at like anterior hip mobility is really important. If they're really overextended, they may be having like a really femorally rotated internally knee. So if they're really overarched, they could have some impingement like FAI, not symptoms, but just FAIs, like the more anterior pelvic tilt. You drive internal rotation, that might be pushing the foot into pronation. And if they can't posteriorly tilt in a proper hinge or squat pattern when they land, they might not be able to physically get their knees out of the way of the acetabulum over coverage. So I would check. I find oftentimes that like hip flexor, quad, adductors, anterior adductors are like really commonly missed. If you look at a Faber and a Thomas, you should be able to pick that up. So check those out and see if they have anterior hip mobility issues. Loads and loads of single leg strength and stability, very, very important. And then just like you said, teaching them how to land properly, teaching them how to run properly, just not like wacky noodle arms when they run, but if you run straight ahead, your feet will tend to stay straight ahead. If you run side to side, you're going to be leaning and you're going to have more traction probably when you go. So and then teaching landing mechanics as well. So that was the longest answer I've ever given, and I really apologize. I hope
you're fine. It was helpful.
Does that clarify everything? Does that make sense?
Yes. Thank you.
Great. Yeah, no problem. Keisha, shout out Keisha. Keisha was one of my students, everyone, and she was a wonderful gymnast.
Thanks, Dave. I don't know about that. I was just gonna follow up on the PAO, because I had a surgeon threaten to do that for me. But what I hear mixed reviews on return to sport, return to impact, return to high level activity, especially in these younger 15 to 23-year-old, typically female, but population.
Yeah, it's something I'm actively working through. I was reading the literature on that, and I didn't know he had talked about like labral stuff versus a PAO, and this, I highly respect the surgeon. He's amazing. He's a really great surgeon up here. But I was wrestling with that in my head too, and given my lack of experience with like this type of surgery, I've treated obviously like 50-1 of labral issues and non-conservative stuff or just labral repairs to PAOs. And I was skeptical until I heard and read her post-op note that her angles were so low, like an 8-degree under coverage. I was like, whoa, that is very, very low. And then also that she did not really have any labral issues on MRI. So she had some like labral fraying, like a small tear, but anybody in here who maybe has read some of that research is like, that's not convincing that they need a labral repair. So they actually didn't even fix her labrum. It was fine when she went in for her pre-op CT scan and stuff like that. So I think his thought, and I guess I agree with it now, is that she wasn't having intra-articular pathology from like a labral symptom issue or something like that. She was having like true instability, and she was like subluxing all over, the place when she was doing leaps and jumps. She had like a lot of groin pain, but no labral repair, no labral issue. She had a ton of outer hip pain, but no symptoms that would, in like no bony wall, irritation, no lateral wall impingement. She was just having like very deep, diffuse aching pain that she couldn't even walk anymore. She was like crippled. So I think because it was a couple times she'd had that, and then his operative report, when she did have a femoral cam lesion, so that could have been part of the reason. But she, under anesthesia, he was like, I was moving that thing all around, like it was really going buck wild. And when he fixed it, he said that the reduction was very solid. It was very good congruency. Her motion was great, and she was very stable under anesthesia. So that was promising. But I'm not gonna lie, she does have some like rectus femoris tenderness right now. And in my head, I'm thinking like the change in angle is really going to make a big difference when she goes back to jumping and leaping and kicking. So I think we're going to probably have a conversation that her expectations to get back to the exact skills she wanted to do on beam and floor, especially with jumps and leaps, are probably going to be not what she wants. And she'll probably struggle with a little bit of like discomfort here and there if she goes too hard. But the exchange is that she has much better congruency. And the other big concern I think that a lot of the research does support is that people with severe dysplasia have significant cartilage issues down the road. So they really have a ton of problems. So I think he was weighing the immediate sports ability and short-term gains for long-term possible cartilage damage if he left her alone and let her keep doing gymnastics, when she would have had to have like a microfracture or an oat surgery. And in her mind, she was like, I'm going to college. I've trained my whole life for college. I have a scholarship. Like, I don't want to miss out on my opportunity. So she tries to tough it out. Has half a season freshman year, gets really, really bad with her cartilage. She gets a surgery by end of freshman year. She's out a whole year for that, coming back junior year. And in a blink of an eye, her college career is over. So we talked a lot about this, but I mean, I agree with you. I think even 3 months now, I mean, she's doing really well exercise-wise, more progressing, but like she still has limitations in hip flexion. Like she can get like 120 if I abduct her, but I don't think she's ever going to have straight flexion back like she used to, because now she has literally less over coverage to work with. So maybe that will just be her kind of like, her price to take on as she moves forward, and just modifying some skills.
Mm-hmm.
So wow.
That'll be interesting.
I know. I did think about doing some like case study write-ups on her, but she's having, her own world. And I just wanted her to be happy. So I was like, just go along your rehab and like, let's do it. But yeah, she's 3 months in now, and she's with me till 6 months till she goes to school, and then she'll have a full training staff. But I told her in advance, I was like, this is literally a 9 to year long surgery repair. So like, we're going to be barely touching tumble track around 7 to 8 months, and I think she understands that. She's got a full medical staff. She's willing to do that. So I feel good about it, rather than someone who's trying to rush back at 6 months. That'd be tough, but she's doing a full strength program with us. She works out with our strength staff and stuff. So I feel okay about where we're going. I'm just crossing fingers that we don't have any headaches down the road with long-term tendinopathies.
So I have an 11-year-old level 7, had a calcaneal avulsion fracture on her right side when she landed a tumbling pass short. And the research on calcaneal avulsion fractures, especially in like pediatric population, is like done.
Yeah, 50-year-old men break their heels, nobody else.
Right. And I mean, on one hand, I was like, well, it kind of makes sense, because I feel like, yeah, like her bone's probably going to go before her tendon goes at that age. But on the other hand, I'm like, so the doc that's managing it, not like doesn't have a huge gymnastics background, casted her for like implantar flexion for like 4 weeks, put her in a boot for 2, and was like, all right, you're good. And I was like, I don't know. Right. So I kind of more like an Achilles repair with like a slightly sped up time frame based on bony healing versus soft healing. So we're at about 12 weeks, and I'm starting to like, she adjusted more of a return to run testing, which she did decent on, but like that force generation out of like the injured side is just, we got nothing.
Yeah. Okay. Was her calcaneus fracture like on the Achilles insertion of like her growth plate back there? Okay, got it. Yes. So a couple things here. One is I like completely underestimated and undervalued, one, how important the soleus is and the posterior tib is, and two, how freaking hard it is to get that strength back. So I actually learned this from Chris Johnson, who's a very high level running PT. 64 to 66%, depending on the study, of your running gait comes from your soleus. So think about that. Almost 3/4 of your body weight in propulsion force is going to come from your soleus, right? And if you have been put into that plantar flex position and you've been out that long and you have bony healing, like all the factors we could talk about that reduce neural drive and just atrophy, right? She probably has like a very, very, very low activation and motor unit threshold recruitment for her soleus and posterior tib, but she also just probably lacks straight up strength. So I would say, and you maybe have been doing this, but I would be absolutely hammering seated deficit calf raises for at least 4 weeks. I would be doing a ton of posterior tib heel raises. So if you squeeze a ball between your heels and crouch down, you're probably biased more to the posterior tib. I would do a ton of those. I would also do a lot of, and I got this from Chris, a lot of like iso generation holds, tiptoe walking over hurdles, hands behind your head, tiptoe walking like a little reptile or like a little like T-Rex over the hurdles. To get some of that like high threshold isometric strength. And do you have access to a dynamometer?
Yep.
Yeah. So dynamometer her soleus. I think I've been doing this more Dan Pope taught me this because he has some Achilles repair people that we were looking at. So you put the strap over their knee and you put the strap goes under their foot on top of their knee. Dynamometer is on the shank of their distal femur, and you just bend their knee back so that the force generation is directly down in line with the dynamometer. So if you like their knee is straight, they kick and it slides off their knee, but bend their knee back slightly so it's directly underneath the dynamometer. And then she can just do a max force generation of soleus and arguably, posterior tib and some other stuff. But I think that would give you a really good idea of like how weak is she. And she would probably, I would assume she has a massive deficit. And then I would just make sure that her strength conditioning principles are in line with like hypertrophy and max strength. So she should be doing like 3 to 4, 4 to 5 sets of 8 to 12 with a weight that's enormous for her body weight. And so I've unfortunately had a number of Achilles tear patients who are like in the 17 kind of high level. It doesn't really matter level, but like these girls are doing like 90-pound soleus raises with kettlebells, like on a 2-inch deficit. And they're like, yeah, it's not that bad. And I'm like, God, geez, your calves are insane. Like I couldn't do that. Right. Cause they just have such a high training age for that kind of stuff. So I would try to really push the threshold of seated calf raise work and just put a big pad between their knee because it hurts on their femur. But and the heaviest dumbbells that she can tolerate with walking farmer's carries on her toes and just doing like kind of those more bent knee calf raises. I would really go crazy with that. And same thing with the posterior tib raises. I would put a weight vest on her. I'd have her hold dumbbells. I'd have her, have a partner jump on her back and like, be a piggyback ride, whatever she needs. Because I think this is just general and medical. I think one of the things we are notoriously awful at really training well is like the direct soleus posterior tib complex. We just do tons of straight legged calf raises. Then, so I would do that. And then I really love just basic plyo progressions of like pogo hops and scissor hops and in and out hops. Are you familiar with those?
Yep.
Yeah. So have her just do low level plyos, but focus on 50-50 weight going through both and tell her max effort, right? Like I don't want you to jump super hard, but I want you to push really hard every time you do and see how that goes along. And honestly, even though she's 12 weeks out, I wouldn't be afraid to use some stem on there too. Like I use back to the hip thing, something that's been really helpful early after stage repairs or stuff like that is putting stem on the glute med and doing rhythmic staves with a trigger we have and doing some assisted that work because it works for the quad. It works for the infraspinatus. There's no reason it can't work for the glute med. There's no reason it can't work for a soleus. So we've strapped on some e-stim to some people after like an Achilles repair and had them do some activation work with that. So she might just need she's young, right? She's young. She doesn't have the intention, the high threshold intention that maybe a 17-year-old athlete does. So maybe she needs some help from the stim to maybe pull on some more motor units that are kind of high threshold. That'd be my thought process.
Yeah, no, that's really helpful because I think at this point, we've been trying to push a little bit more of like the strength training stuff when she's coming in. But when she goes to the gym, her coaches are like, well, just go do heel raises off like the wall bar until you can't do anymore.
Yeah. Yeah. So she's getting a metabolic limit, first of all. But also and this is just how I conceptually think about it, is like the gastroc has more type 1 fibers and is maybe more that slow balance postural control. But the soleus, especially in fast twitch athletes, have a lot of type 2 fibers. So how do you recruit type 2 fibers? You have to overload them with mechanical load or burn them out in BFR, right? But you have to put a high threshold load on them. That's what like back squatting does, is it unlocks type 2 motor fibers because you fatigue out and you need more gas in the tank. So doing heavier loading or with stim is probably theoretically maybe going to tap into more type 2 motor fibers that she needs that she probably can't do on her own volitionally because she's got so much stuff going on. So yeah, I would be honestly pulling away some of the straight legged calf raises and just having her go a lot of bent knee work and then having her do a lot of like double leg to start. And then single leg pogo hops in place are amazing, but single leg dumbbell pogo hops in place are great. Like I really love those a lot. So just standing with 2 light dumbbells and just single leg pogo hopping as high as you can. There's no way out. You can use your calves so you can't. So have her bend her knee a little bit to get more of the soleus bias, and I think that will help. And then skipping, hopping, stuff that you're clearly probably gonna be good at.
Cool. Thank you.
Yeah, no problem. I like all your books, by the way. Are those CDs behind you? Are those CDs?
Oh gosh. So I'm at my parents' house. This is my dad's office. So yeah, there's CDs. There's definitely probably cassette tapes. These are cassette tapes.
I have like massive ADD. So I was like, at the end, I was like, oh my God, look at how many CDs she has. That's incredible. Like a vintage shop. Sounds good though. Great question. Yeah. And I think that helps a lot of people with many other things. Severs, I use the exact same approach for a lot of these stuff.
So Dave, you've actually seen this patient virtually.
Yeah.
This was the patient River.
Yep.
And So I'm thrilled that you're doing this. I think, you've given so much to medical providers trying to help this population. It's invaluable. So she's doing really well with the strength. Like, we didn't have a dynamometer, but we've tested her repeatedly, and she's very consistently,
Cool.
4+5 most of the time. Like a little bit needs some facilitation, like some activation work before she really tests a 5.
Yep.
So anyway, so we're trying to, get her back into the gym, and I'm struggling with, like, where do we start? Like, her shoulder mobility is fine. We've screened all that as far as, for back handsprings. We've tried back handsprings on tumble track. She's tolerating it well. We haven't done any bars. I just kind of am at a loss, and I just want to make sure that we, what your thoughts are as far as progressing her back to skills. What would be the safest?
Yeah, absolutely. I'm happy to answer, and thanks for the kind words. I'm happy to help. This is an amazing question, because this is something we all struggle with. I still struggle with trying to, like, figure out this ridiculous sport of how to do this. Like, I'm pretty mad at, like, Mike and Lenny with baseball players. Like, bro, you got it so easy. Ball, it's so easy. But yeah, so I've evolved my thoughts more, and the course kind of reflects this. But I always say the first step of getting back to the gym is gymnastic specific strength testing, right? So, like, it's great to have her MMT is good. I'm sure she's crushed the strength program with you. You're doing great, but she has to show us that she can comfortably work in all 4 planes of motion at a high threshold, right? So she has to be able to do pull-ups. She has to be able to do some version of a piked handstand push-up with good control. She has to be able to do really high quality push-ups, and she has to be able to do really good feet elevated horizontal rows, right? And I think a really good way to, how do we say this, politely tell a gymnast they're maybe not ready yet is to use some of these strength index testing, because they can do like 15 push-ups or 25 push-ups, no problem, but they can't do like 7 feet elevated rows without like dolphin kicking their way up. So it shows us that they have a massive strength imbalance between their upper back and their rhomboids, their middle traps and stuff like that, and their anterior chest and push-ups and stuff like that. And usually they get back to like pull-ups pretty well and rope climbs, but they have a massive deficit in either the quality of the pull-ups and push-ups they can do, or the mismatch of how many rows they can do to how many push-ups, or how many pike handstand push-ups they can do to how many pull-ups they can do. And that kind of shows you that, like, all right, if we don't have just a balanced shoulder from a front, back, up and down point of view, it's not going to go well when we start basic bar swings and stuff like that. So that would be one thing. And then the same thing related to strength testing, right? If she's super strong on her MMTs for like lat, teres, pec, stuff like that, but she's still coming along on her cuff, that can be something you can explain to her. But it typically is, by this point, she's doing really well with the cuff work. So I would say focus on that first. And the next phase of that, which can sometimes go alongside what you're doing on tumble track and stuff, is just starting with basic drills and basic shaping and stuff like that for the event she wants to work on it. And I would involve her coach, I would involve her, whoever else it is. But when my own athletes come back after a shoulder injury or something like that, I literally have them do very minimal actual bar swinging, and they're just doing all the drill circuits. So they're doing like handstand pike rocks, wall handstands, pirouettes, spotted work on floor. They're doing L holds, they're doing leg lifts, and it reconditions their shoulder for very unique demands that bars puts on them, right? Same thing with vault and floor. They're doing 3 times through the drill circuits that everybody else is doing, and then taking 1 vault that's spotted with me. So I'm having them do cartwheel step-ins, I'm having them do handstand pops, I'm having them do all sorts of dynamic work for their shoulder, elbow, or wrist. That is essentially like, some people say you got to go back up through the levels. You got to start at level 2 again and go all the way back up 3, 4, 5, 6, 7, whatever else it is. I don't like that terminology because it makes them feel like you're starting over again. I just tell them that we will have to start with basics and technique and drills to recondition their shoulder. Because I mean, any therapist in here, it could be, you could have the best facility in the entire world and do the best thing, but it is not going to mimic even half the demand, a quarter of the demand that they're going to take in a 45-minute bar rotation. So I think that getting them back into the gym, but saying like, just do all the 7 drills that your coach puts up for you. And if there's one that bothers your shoulder or it's too much, just regress it somehow. So I have them do that for a couple of weeks. And I think that really helps their mind get back to a really successful return. But we know that like the leg lifts, the handstand holds, all the different drills they're doing, the round offs on blocks and stuff like that, the handstand pops is force overload compared to more what they've done previously in the clinic, or even, where they're at now with you. So I would do 2 weeks of a really advanced strength program combined with that 2 weeks of a drill approach and see how that goes. have them do every other day. Don't have them do 5 days in a row. Have them do Monday, like she goes 6 days a week, or 5 days, do Monday, Wednesday, Friday, and Tuesday, Thursdays are her like PT and strength days, and leg days and core days. So it's a traditional periodization loading of like on-off cycles and giving her time, but she's doing things that are very specific to what she has to get back to. And for younger level athletes that are, maybe just doing basic front handsprings and stuff like that, then they just do the drills and work up to it. But for really advanced athletes, and I know this athlete is, she can start doing some drills for release moves, like, barrel on a feet, drop, hinge, or like when she first learned to shoot over, or just some strap bar swings to learn on her Jaeger tap and stuff like that. You can work those in as drill side stations and dose response her to see, how do you feel? What was your pain level, during and after? Was it under a 3 out of a 10 during it and after? The next day, did it not get worse? If so, let's try to go again on Wednesday, and then maybe take the week lighter towards Friday. So I would just do all that. I would do that for 2 to 4 weeks. And then from there, you just continue to progress up that ladder. You say, like, okay, what skills are more basic for her or for you that you need to work on? Maybe it's giants, maybe it's Yurchenko timers. And you start doing those for drills, and you start making those become the things she's dosing more and more. You have her get spotted on some cast handstands. You have her get spotted on some giants. You have her do strap bar giants. You have her do low bar blind work or pirouette work with her coach. You have her do Yurchenkos with a sting mat on top of it. You have her do more soft resi Yurchenkos or something like that. You have her going to the pit. And you just would progress your way up to that. I mean, there's a longer discussion about, writing specific programming for, sets and reps and exposure and impact and skill dosage, which we can happily talk about. But I would probably approach that first for another month and see how she feels with that, and then start slowly weaning into actual basic skill work. So does that help? Is that
Yeah,
help?
yeah, that's really helpful. I mean, we've done some of the handstand pike stuff and the some L holds and stuff in the clinic. We've done some of these things,
Right.
but again, I'm not in the gym with her, so I will, I think, I'll just have to reach out to her coach, and, they're a little more resistant, but.
I'm aware. Yeah, involve the parent too. Like, have the parent talk to the coach and tie you guys in, and, have the coach be like, what would be ideal for you to try to do? And then, like, what do I think is a little bit more, I guess, realistic? Then just meet in the middle. You're going to be like, what do you want to do? Like 4 routines with Jaegers. You're like, all right, it's a little aggressive, maybe some drills. You guys will meet in the middle on maybe some strap bar taps, something like that.
Yeah, that's great. Thank you.
Yeah, no problem. Cool. I think I had there's one that came in. One came to me via direct message, Sarah. So I'm not sure if you saw that one or not. I can copy paste that in. Jocelyn says, what do you do for girls that toe walk all the
She'll
time?
talk. She can.
Oh, sorry, Jocelyn. I stole your thunder. Go
You're
ahead.
fine.
So is there anything more to that question, or is that just the question?
There's quite a few girls at the gym that I work at that toe walk, and I don't know what to do for them. I've checked a lot of them. It's not like hip flexor because they have that anterior pelvic tilt. And so I figured maybe that was it. And none of them have that. And I know that stretching doesn't always help when it's spastic like that. But the issue is getting the parents to do anything, because they're like, oh, well, gymnastics is a good sport for them, right? Because you guys are always on your toes. And I'm like, yes, but no, they still need to be able to dorsiflex. So I don't know, like, would you do just foam rolling, or is there anything else aside from that you would do to help?
Yeah, well, yeah, it's probably obviously going to be a more like cultural / like habit thing. He probably doesn't have true, neurological plantar flexor tone. But yeah, I think on the parent side, education is key here, because like, yes, it is a toe pointing sport, but like they land 1,000 times per week, and like look at the amount of dorsiflexion they need. And I mean, we frame it as a injury type thing, but they want to frame it as a performance thing. Like, do you want her to stick more landings? Do you want her to be more powerful? Do you want her to be able to run faster? Because you need dorsiflexion for energy propulsion and for absorbing a force. So I would spin it maybe that way a little bit, just in terms of like the buy-in point of view. Yeah, and I think foam rolling became all the rage, and I was someone who like advocated for it, but I spend maybe 4 minutes on foam rolling in a 4-hour practice. Like it's very, the research is clear. 30 to 60 seconds, consistently done every day, along with stretching. You can get range of motion increases, but they're temporary, and they're typically more like relaxation or the desensitization of nociceptors. They're not really true structural changes. So I'm like way more on the eccentric side of the fence for actual load-induced changes. And I mean, we do not have to go down the rabbit hole of why eccentrics work. I'm happy to share it, but essentially, we followed in our warm-ups of doing the stuff that we've read is more in like RDLs and barbells about doing like a 5-second lower with a 5-second hold for 5 reps every single day. I think it was two rounds. Did start to have plastic changes in the length of sarcomeres sarcomerogenesis, like in length, but then also collagen changes too. So something about heavy eccentrics, whether it's on the mechanotransductive wavelength, if you're into that, or you're more in just like the actual stretching of collagen over time, for some reason that seems to be really, really helpful. So I really like, again, seated calf raise eccentrics for this, but then also doing like standing bent knee heavy eccentrics. So have someone push on their shoulders and have them just do a very slow eccentric for 5 seconds, hold the bottom for 5 seconds, and then partner takes their hands off, they push back up on a concentric, no weight, heavy load on the way back down all the way through. So they can do it at home on their own. They can do it during practice at the side station. They can do it as a warm up. They can do it with a partner. I toss them in for conditioning because it's the only time I feel like people give a crap. So we do it at the side station after like rope climbs and stuff like that to do it. I think those are usually better. But yeah, if it's like there's a true structural issue where they don't have dorsiflexion, it's that plus the stuff we talked about before, maybe with the calcaneal issue. If it is a habit thing and it's an awareness and a cultural thing, it's more about conversations about why both are needed. You know what I mean? Like why, if you want to land on beam and not fall off, you need dorsiflexion to land your leaps and your jumps. If you want to stick your landings, you need dorsiflexion to do that. If you want to run faster and have a bigger vault, you need dorsiflexion to run. So I don't know, which do you think that like there's one of those two things that stands out more or no?
I don't think, at least for most of them, it's not a cultural thing, because one girl like today, she was in another coach's class and she called me over, and even when you ask her to put her heels down, she like still is like that far off the ground. So she's pretty high up in planar flexion. And then when you ask her to lower, she still can't get all the way down.
Yeah, that sounds like a habit that turned into like a true mobility issue. You know what I mean? Like she developed true stiffness. And I mean, God, if I was like her coach, I would like try to show her parent, like just watch her when she walks around, like her heels are not touching the ground when she walks. Like she's gonna get a raging Achilles tendinopathy if she continues to do that, because it's like someone who has limited knee extension after an ACL. They walk around in a bent knee and get a really bad quad tendinopathy because it's just there's no break. You know what I mean? So there's multiple performance arguments for that stuff, but two is like if she develops a degenerative like stiff tendon that's like really aggressive, she's doing heavy landings, she's going to spend more time out on the PT stuff down the road, probably because of this kind of like progressive nature. So I would just hate to see it only happen and change because she, her mom all of a sudden is like, oh God, we have an injury now. Like I think you should try your best to educate her on like, here are 4 performance things and here's some injury things that are all possibly going to be concerning.
Okay.
Yep. Good question. Hello.
Perfect. So I've had an athlete out, I guess we're probably pushing about 4 months now. I believe the final result of the injury was an ankle injury, is bone bruising. She's finally been given the okay to come out of her boot, but they don't have her doing any physio at the moment, which is the most frustrating thing in the world on my end. Yeah. So I've never had a girl out with any injuries, thank the Lord, especially a foot injury. So it's kind of just, where do I go? What do I do? Especially with bone bruising, where she's been in a boot for almost 4 months.
Yeah. It's tough. Hopefully by the time she's at now, the bone bruise is completely resolved. I mean, I think sometimes they last a long time if they're bigger, but if she's definitely in the boot, I mean, the first thing you have to check is just like a conversation about dorsiflexion. You have to check her ankle mobility and make sure she has enough ankle mobility to safely jump and run. Because if she is stiff from the boot and then tries to either do any light level plyometrics, she's going to either strain the injury itself or develop like an Achilles issue or something like that. I see that happen a lot. So I would screen that and work on that a lot. And if she doesn't have an issue, I personally always like to start with general plyometrics first for these athletes on a harder floor setting, like a spring floor, and then go to tumble track. So I personally think that tumbling on tumble track and jumping on tumble track is very similar, if not more stressful than low level plyometrics on the floor. So the kind of the standard routine that I always have people do is 3 to 6 weeks, depending on how bad the injury is. So it's 2 weeks per phase if they are in a more severe injury. It's 1 week per phase if they're in a mild injury. So I don't know how bad the bone bruise is. It sounds like it's pretty extensive if she's in a boot for a long time. But I would have her do skipping and jogging and just side shuffling first to see, because that's very low level. It's very, very benign. But I would have her like skip down and back, side shuffle down and back, jog down and back, backwards jog down and back, and just see how that feels first. And if that goes well, you can do pogo hops, scissor hops, in and out hops. I do 20 each of those, 3 days per week, along with her running stuff, and just see how that feels first. So if she can do all the running, all the jumping, all the skipping, all the pogo hops, all the scissors, all the in and out hops, and then maybe even doing some like front to back hops and side to side hops, like steers over a line, that's usually around 200 ground contacts of low level plyos. And the dosage during it, right? You're like, okay, is it sore? Is it not? If it's a little sore, I go under a 3 out of a 10. I'm like, all right, we're okay. Let's see how you feel tonight. Let's see how you feel tomorrow. And then we'll do this again, maybe, a day or two down the road. I would do that for a week first, twice. So I would do like on a Monday, take 2 days, do it on a Thursday, and see how she responds to that first. And if she is like totally fine with that, I would increase the plyos the next week on a harder surface. So high skips, double leg, mini broad jumps. So just bouncing forward in a row, bouncing side to side, box jumps, depth drops, single leg pogos in place, single leg line hops back and forth, single leg side to side, line hops and forwards. I would do the exact same thing, just with single leg movements and more aggressive double leg movements, and see how they feel with that. So I do that for another week as well, 2 times, to see how they feel. And if they go through 2 weeks where they can get to like connected mini broad jumps and single leg hops, I usually feel okay with some of the way they're progressing back. And then I would kind of go back to the tumble track, tramp, just jump on tramp for 10 minutes, do some jumps, do some leaps, do some round offs, do some basic stuff. And usually the combination of higher level trampoline type stuff and the lower level ground general physical preparation stuff is a good mix of force overload for them, but it also kind of gives them an idea about how they're feeling. If they're doing well, I allow them to go farther. If they're not doing well, I pull them back. So I would start with that for probably like 2 to 4 weeks. And then when it comes to terms like, okay, they're tolerating all the plyos, they're tolerating trampoline, it's fine. I think I've had success with this, and I still stand by it, that like an objective return to impact program with skills is really, really important. So you have surfaces to work with, tumble track or pit versus tumble track versus rod floor versus hard floor with a sting versus hard floor, right? Like that's the spectrum you can work on for impact. Same thing with dismounts, right? Pit, soft, resi, 8-incher, or sting mat or something of that nature. So you have the surface they can work on. You can have the number of skills that they do, right? So 5, back handsprings or back tucks or whatever versus 7 the next week, more. Then you also have the skill difficulty itself, which is force per skill. So a back handspring is less impact than a back tuck, which is less back impact than a round up back handspring back tuck, which is less impact than a layout or a full, right? So like I usually manipulate those 3 variables of what surface are they working on, how many are they doing of those specific skills, and what's the difficulty of those skills, and I dose that 3 days per week. So it's like, okay, on floor, we're going to start on tumble track. You're going to do 5 back tumbling passes, 5 front tumbling passes. Bars, you'll do 5 dismounts to a soft mat. Vault, you'll do a bunch of drills in this, and then you'll do 5 of each of those things. You'll stop at that capped number. Tuesday, you'll take a day off. Wednesday, you'll try it again, see how you feel. And I do that for 2 weeks. And then I increase to the next one, which is like, okay, we're going to go on the rod strip, but do the same number of skills, the same type of skills, and see how you respond to that for a day. Then we'll increase the force per skill a little bit. Let's do some layouts or some back layouts and front layouts instead of tucks, tumble a little harder. And then also maybe let's throw in some extra jumps and leaps and dance and stuff like that. And the next phase, the last phase is like, okay, the real floor with your basic passes first at this volume, 3 days per week. And then lastly, the last phase is let's do all your skills, put a cap of 7, no more than 7 back or front passes or dismounts. And usually that whole process from like, if I had somebody with like a big ankle surgery, like a cartilage issue, and they were getting back slowly, it'd be like 2 to 4 weeks of the plyos themselves, and then another 2 weeks of the tumble track plus plyos, 2 weeks for the first phase of the low level with low surface, 2 weeks of the medium stuff, 2 weeks of the hard stuff, 2 weeks of the cap for 7, don't let it go over. And I know that's a long timeline, but that's the only way that I've found people objectively get back and not have long-standing problems is like a solid 2 to 3 month graded return to sports progression. And that's usually happening after a 1 to 2 month, like very aggressive strength conditioning program with like split squats and step ups and deadlifts and med ball work and jumping and box jumps. Like they're doing so much strength work before that when I get them to that beginner plyo stage at like 5 or 6 months, whenever the surgeon clears them or stuff like that, I feel really good about how much force we've put on their ankles up to that point. So not saying that you're in that situation, but just trying to add value for everyone here. That's probably how I would approach that situation with like chronic bone bruises, shin splints, Auschwitz slaughters, any impact lower extremity injury, which is like, half of the stuff we see in gymnastics, I'm very strict about when I teach them early on about like, this is what the timeline looks like. Like, you're in a lot of pain now, you're coming out of the boot, but like, it's going to be 3 months to get back to full impact and things you want to do. And just like buckle up for that, 5-month period where like, I don't hurt at all. Let me do all my floor tumbling passes. Let me do all my dismounts. Yeah, I get that. But if we let you go through the honeymoon phase and just try everything, 2 weeks are going to roll by and you're going to have a delayed effect of like, wow, my ankles are really sore, or my Achilles hurts, or my knees hurt a little bit, because they're not used to that high volume impact anymore. So I don't know. Does that help? Does that clarify?
It was definitely helpful. The biggest challenge I'm facing right now is, one, we're not even back in the gym.
Mm-hmm.
We're still doing Zoom training and slowly getting towards some outdoor training. So obviously there's no like tumbling or anything as they're on concrete or glass. But even just getting her into training has been my biggest issue. And obviously that's a parental concern. But overall it was very helpful. Obviously, as far as like all the trampoline stuff goes, there won't be any of that. And at least with that, the whole group will be doing it together. So I think she'll feel better with that.
Yeah. You can get if she has some space and some place to like run or jog, you can get a lot of that in a home training program. You can get all the way up to like single leg weighted pogo hops, and skipping and all that kind of stuff. She can get a lot of the way there on her own at home. I think, the parent stuff is a whole different ball of wax, but I think up to the first half is you can probably do a ton for her at home. With all the kind of stuff we were talking about.
Thank you. I'm glad to know that I'm on the right track with it. I appreciate it.
Yeah, no problem. Happy to help. Sweet. All right. I think I just got one for the next one. Sarah, this one next. All right. How to safely return to plyos of upper extremity after restoring range of motion and slow heavy loading strength after shoulder impingement injury. Okay, great. Awesome question. I'm happy somebody asked this because I think this relates a lot to shoulder issues, but also OCD, which is like still a massive problem in gymnastics. We can have the OCD discussion if anybody wants, but so I'm happy the question before just came. I treat that almost exactly the same way that I treat the upper extremity, right? So spoiler alert, we're actually publishing a paper right now with a surgeon up here, Luke O, and a couple other people, Jen King, one of our students, on return to gymnastics after OCD. It's an entire comprehensive program of like, from the second you get diagnosed to getting surgery to going back to full tilt. What do you do for elbow OCD all the way? Like a UCL surgery they did with like baseball, we're doing that for OCD in the elbow. So, which is great. But I think in that situation, the exact same parallel concepts come to the ankle or the knee or the hip or the back and the upper extremity. So first of all, is that a slow introduction of weight bearing is important, the same way you would get someone off crutches, like quadruped rocking, going to bird dogs, going to bear crawls, going to pike tucked handstands. Like, you got to do that progression really, really well, so someone's shoulder doesn't get sore going too quick, too fast, because the compression of the handstand is way different than a compression of just like, a dumbbell press or something that they're doing in the clinic. So make sure that progression is slow first and appropriate. But when you're actually like cleared, strong, mobile, which sounds like it is, I do the exact same thing for the upper extremity that I did with the lower extremity. So you can't do, pogo hops for your arms, but I do shoulder touches, in a plank, fast shoulder touches, or like shoulder shrugs, bounces on trampolines, or a wall rebounder, or plyometric push-ups in the clinic, or handstand shoulder taps, or something of that nature. Those aren't like true plyos, but you can do some sort of mimicking motion of like fast reflexive work of the upper extremity. Med ball chest passes as fast as you can, overhead passes, single arm dribbles on the floor. Like, those are really good ways to mimic the quick elastic force that they might need in gymnastics. And then you go on to, like I said, push-up hops on a floor or on a springboard or on a trampoline. Those are great to do. Handstand pops on a trampoline are really great to do. Any sort of like impact related drill. So just like sliding down the wedge. You've seen that drill where they like have the wedge up like this and you slide down and kind of hit in a hard impact. Those are really great to do as well. So I would dose those exactly the same way I just did in the last question about pick 5 or 6 that they can do with med balls or push-ups or whatever else, dose them 22 rounds, 3 days per week, and see how they tolerate those kind of things. So see how it feels to do, these 200 arm contacts or ground contacts Monday, Wednesday, Friday, or just Monday, Thursday to start, see how they respond and see how you go with that. So the push-ups, the handstand pops, the drills, stuff like that in the clinic, the med ball stuff, whatever else you can do to mimic some of that. I would do that for a week or two. And then I would start to do the same idea of a 3-day per week exposure plan of the things they're getting back to, but on softer surfaces and lower numbers. So I would do back handsprings over a roller. Some people, like with OCD, big surgeries, have to start that early, where they literally just do back handsprings over a big rolly wedge because it takes off some of the impact on their hands. So I would do 10 of those. I would do standing back handsprings for some people on trampoline. I would do different types of bar release drills. Like if they're coming back to a high level skill, have them do 10 shoot overs to a push-up hold as part of their rehab in the gym. And you would just find all the things they have to do. Some kids are just on front handsprings. So put the table real low, or do a drill and do it over a resi with a soft surface. You can mimic that, or a half on for a souk or something of that nature. I would do that. I would just do some of that really slow exposure of those things 3 days per week, and find whatever, numbers are appropriate and days are appropriate, or equipment they have and stuff like that. So do that first for 3 days. And then exactly the same way before is you increase the surface, where you can put them on the rod strip with a sting mat now, or you can put them on a hard surface. You can increase the force per skill by taking away the barrel and having a spot, or doing a back handspring step out or something of that nature. You can increase the actual volume of the skills themselves. So do 7 of each thing 3 days per week instead of doing 5 of each thing 2 days per week, and seeing how they respond. And then you can also do some other things related to writing a program for their strength to get a much harder too as well. Hopefully it's increasing on the same side, but a lot of the strength conditioning they do for upper body conditioning has a plyometric or a really heavy loaded component to it. So yeah, do the exact same thing you would do in a lower body, and just dose those things 3 times per week. Think about those 3 factors of increasing slowly over time. And then eventually it becomes a skill exposure program where, if they're younger level and they're not doing releases, but they're doing back handsprings on beam, you have to really just play with like the vault impacts, the floor impacts, and the balance beam impacts to not stack those up in one day. Spread those out over a couple of days. If they're very high level and they have, shoot over hand, they're also doing a Jaeger, they're also doing a Yurchenko full, they're doing, a layout step out on beam, they have 3 hard tumbling passes. Just try to break those up again and mix and mingle around that kind of stuff. So just try to objectively look at how many estimated arm impacts are they doing on what surfaces each day, and write a program that goes across from it. So once you write one of those programs and you kind of go through the course we put it up for free somewhere else on a blog. But once you learn how to do that, you start getting templates of different body parts that you can kind of go back to, right? Like, I differentiate a lot of the stuff I do between like a Sever's disease or an Osgood-Schlatters or a hip, but generally speaking, my plyo progressions are kind of similar with small tweaks. So the templates I've built out in Excel, and same thing for the upper body. If I have an impact-based upper body injury, whether it's gymnast wrist, whether it's elbow OCD, or a shoulder impingement with somebody getting back to traction and compression forces, I have a relatively similar template that I use for a lot of people. I plug their own skills in. I talk about their goals, their timeline, their levels, and we change things a little bit. But taking the time to write those templates out in advance and knowing like in your head where you want to go with progressions saves you a lot of time in the clinic down the road, and gives people something objective to look forward to on the first day. So hopefully that helps.
So I have quite a few gymnasts that have hernias that they were born with. I don't really know anything about hernias other than what they are. And a lot of the moms are like, oh, she can't do any kind of core stuff, no planks, no sit-ups. So I've listened, but then at the same time, they're so weak that they're not progressing and the parents are getting frustrated.
Right.
So is there anything that you can safely do to strengthen their core when they have a hernia? Because like, especially with bars, they can't get their pullovers. They can't really do anything that involves their core.
That is very hard because in my experience, I've not treated a ton of hernias, but Dan Pope, who's my coworker, has treated a ton of these in like powerlifts and stuff. The bracing and the compression of bearing down is typically where these hernias are the most prominent. So whether you're doing like direct sit-up V-up work, right, that's obviously something to be careful of, but like it's the landing forces also that are heavy compression based or squeezing really tight. The bracing that oftentimes is one of the biggest provokers of these things. So yeah, I really don't know how to help with the idea about like not doing any core strength from the parents, but still getting upset when they can't progress. Like if they don't want to let them do any core strength at all, you have to kind of accept the fact that they're not going to progress until a medical person gets involved. Like I think they should, this sounds like a tough situation where you're in, but like they should really get with a women's health PT or someone who really understands the female hernia and talk about like, what can you safely do? Because I think from what I've learned, loading it in the proper context helps build resilience against the tissue having a problem down the road. If you just leave it by itself, it's not going to get better. You know what I mean?
Yeah. That's what I told the mom, because I was like, she's only getting weaker and weaker, which is just making the hernia pop out more.
Yeah. And also like, I don't know, sometimes these kids need a surgical mesh put in. Like, I don't know, I've seen a couple of have that. So I don't know. I think an honest conversation with the parents going to be important. Like, okay, if we aren't doing any core strength, we got to really reduce our goals, like really reduce our goals and be happy with whatever happens. And if the kid gets really upset, she's not making progress, we got to be willing to have this conversation. Or do we need a women's health PT consult, or do we need a surgical consult? Like if it's that big of a hernia that it's going to make that big of a deal, that's like a life quality issue. That's not even like a gymnastics issue. You know what I mean? Like,
Yeah.
let that keep going. So, but yeah, in my experience from what I've done, I mean, I think teaching people how to brace and breathe just on their back normally and properly use those mechanics is important. And Dan loads these people up with, you know, farmer's carries and, you know, back squat exposure stuff just to make sure they're okay. But only after they've been cleared by a surgeon, and even after they've been cleared by like a pelvic floor or someone who's a specialist in there. So I'm not that, unfortunately, so I can't give you a lot of advice. But yeah, I would again, I'm thinking more like quality of life down the road. I'm not even thinking about gymnastics. Like we do not want to leave a massive hernia getting worse and worse.
So, yeah, she's only like 10.
Yeah, women's health PT is like you got to find someone along that lines.
Okay, thank you.
Yeah, no problem. Let's take one more, and then I didn't realize we're 15 minutes over, so I'm gonna go. But let's do one more. You got Sarah.
Maddie asked if you have an estimated date for when the ALBA OCD paper is coming out.
Oh yeah, the research fellow who is tying it all together after we edit it is literally writing it as we speak, and so I think we're trying to submit it maybe in another couple of weeks once the edits all get done. And I don't know what journal. I think we're trying to submit to Sports Health, so I don't know what that process takes like. But I would love to see it out by spring. That'd be great. You know, it's I mean, hopefully the surgeon that we're working with has some nice little connections that we can push that here forward. But yeah, it's literally being edited. The final manuscript is being edited right now, and I think that paper took like 2 years off my life, man. That thing was a beast. But I'm really happy it'll be out for a good resource.
Yeah. So. Resources for like men's gymnastics skill progressions. I was a level 9 gymnast, so like women, like fine. Like when people start talking about peaches and P-bars and like, oh, I'm like, I have a vague notion of what's going on, but it's not nearly where my knowledge resides.
Yeah. I'm glad you asked that. I'm glad we got a men's question and sneaking there. Yeah. So there actually, there's a couple like obviously textbooks and stuff that you know from like, you know, championship gymnastics for like Jerry George and stuff that can help you on the biomechanical side. But there's not a lot of great resources for the men's skill exposure. So there's the first thing I would actually recommend is try to watch lectures or study stuff from really, really good men's coaches and just watch them break down basic skills for the kids. So like Tom Meadows is a great example. That dude is a beast in terms of how much knowledge he has. And he's done a ton of Congress lectures. I've had him on the podcast. He's done a bunch of stuff for us. So like, I just watch a few of his like basic lectures on P-bar stuff and you'll see, okay, what's a peach? What's a Moy? What's a Tapel? You know, what's a Diom versus a Stutz? And what are the differences in those skills? So I would try to study the coaches themselves first because they're in the trenches and whatever they're going to do with their drill progressions are probably what a lot of other people are doing. So Paul Sargison is another really great coach out west who I have a ton of respect for. Runs a great program, has a guys in the national team, but he just like films a bunch of his guys working out. So you'll see a bunch of his random drills and stuff like that on. So I would try to find 2 or 3 people and just honestly shoot him an email. Like if you email Tom and be like, hey, I'm trying to look for this for the medical side. Can you give me access to some of your PowerPoints? He would like, Jesus, take them all. Like he would love for you to have some of that stuff. I think he wants more exposure to it. So start there. There are a few books that they're not specifically to men's gymnastics, but they talk a lot about the forces of certain skills. So the Advanced Study of Gymnastics by Monmay Gemini came out like a couple of years ago as a 2nd edition. That's pretty good. The gymnastics medicine textbook that Emily Sweeney edited, I wrote the rehab chapter in that. And it has a bunch of other like biomechanical stuff and some random stuff that, you know, might be elucidating some of that. And then what's the other one? It's by Russell and Kim. It is the Sports Medicine Handbook of Gymnastics that came out a little bit earlier. That was like 2015. But those 3 books together, the sports medicine one, the Advanced Study of Gymnastics, the gymnastics medicine textbook we wrote, and then just talking to coaches will probably give you a really good head start on, you know, just basic ideas of what's difference with pommels versus parallel bars versus high bar and some skills that go into that. Cause yeah, it's a very unique beast if you haven't come from it because like, yeah, like upper bar skills, like Dioms and Stutzes are very different than Peaches and Moys, which are underbar traction force skills. And same thing with like high bar. High bar is just a bananas with the type of skills they're doing versus like in bars or releases. So yeah, trying to get a little bit of exposure from those, but you could probably get a decent amount of information from the books and then reach out to some coaches, watch some videos. Some of the videos on YouTube, like tutorials of just fans breaking down the best skills in gymnastics. They'll go through like, here's the men's parallel bar codes for underbar work, A through D, and here are all the hard skills. And they name them and put the thing of like how hard it is just for fun, but I've pointed a lot of people to those directions to learn like what some of the basics are.
Cool, thank you.
Yeah, no problem. Fantastic. I think we're gonna call it there because we could get carried away and talk all night, but I think that was enough. I'm sorry if I talk very fast and I go through things a little bit quickly, but we are going to record this and we will put this up on YouTube. And if it's helpful, I will try to keep planning to try to get one every month or every other month, or maybe, I mean, I can't promise that, but Sarah's the master of my schedule now. So Sarah, maybe you can make that happen somehow, squeeze it in. Yeah, so we'll do that. But you guys, thanks so much for being here. I appreciate you wanting to learn more about how to help these wonderful athletes. And we will catch you guys whenever we do the next one. Bye-bye.